Good morning, everyone. Welcome. Hopefully it's sunny where you're at. As you guys jump in, if you want to share who you are, where you're from, if you're in Illinois, what part of the state, if you're outside of Illinois, we'd love to see where everybody's from, who you represent, and we will get started in just about 1 to 2 minutes. I already see a lot of familiar names in our chat, so welcome everyone. If you're just joining us, feel free to use the chat. Let us know who you are, where you're from. We're going to keep watching as people jump in, and then get started in just a few minutes. I see a lot of my birth to five friends, a couple ROEs. Looks like we're well represented across the state. I see lots of northern, and then we get all the way to Rock Island, some central, few other northerns. It's great to see everyone. I am going to keep watching the participant numbers as they start trickling down. I will get started. All right, it looks like we're kind of tapering off here, so I'm going to go ahead and get started by sharing my screen and doing a little bit of a welcome and some housekeeping, and then I will turn it over to our fabulous guest presenters that we have today. So, welcome everyone. My name is Kristen Kaufman. I'm the Director of Programs here at Prevent Child Abuse Illinois. We are so grateful that you're joining us. If you have been following us through April, this is our third webinar in our weekly series, and we have been hosting so many events across the state. So if you partnered with us or attended one of those, thank you for joining the cause. But today I'm very excited for our webinar today, Upstream Together in Illinois, investing in the prevention of adverse childhood experiences through policy and collective well-being to strengthen families, which I know is a long title, but I feel like it's really important that we get all of those pieces in. And I am not going to read the bios of our featured panelists. I'll let them introduce themselves. But we have Dr. Bart Klika from Prevent Child Abuse America. We have Dr. Valletta Saxon from the Illinois Department of Children and Family Services, and Dr. Mashana Smith from Lurie's Children's Hospital. And then after they get done with their portions, I will play a recording. I had the privilege of sitting down, well, on Zoom, so not, not in the room, but to spend some time with Representative Michelle Mussman, Representative Lindsay LaPointe, and Representative Anna Moeller, moderated by my good friend and colleague, Dr. Betsy Goulet, to talk about through the policy lens, kind of what's happening in Illinois and some important pieces that they are working on at the General Assembly. I also just want to shout out, I know I saw some of you guys in the chat, but this was not done, on our own. We have a wonderful group of partners who helped make this event happen. They have been in planning meetings. They have made connections. They have given their feedback. They have been instrumental in not just this event, but our entire investing in prevention campaign. So I just wanted to shout out them if you're on here. We truly appreciate your partnership. A little bit of housekeeping. So we are recording our event today. The link to the recording, along with all the additional resources we'll talk about today, will be sent in a follow-up email. We do have a dedicated time for questions and answers. I will kind of be monitoring the chat and Q&A. We just ask if you have questions for the panelists, please put them in the Q&A box. They're just easier to track that way. But feel free to use the chat and the reaction buttons if you have like thoughts that you want to share or things like that. But if you have a question, I just don't want to miss it. So please put that in the Q&A box. And again, feel free to use the interactive buttons at the bottom. Those are always fun. It's as a presenter, it's always a little difficult to stay engaged. So when we see those buttons, it really helps keep us going. So we love to see those. And we are providing CEUs for this event at the towards the end of the webinar today. I will be putting a link to a survey evaluation and a link to request your CEUs in the chat. Both links will also be included in the follow-up email. But if you need CEUs, you'll click on the link. It'll take you to a Google form. You fill it out to request your certificate, and then it will be sent to you in about 1 to 2 weeks. Our partners at Lincoln Prairie Behavioral Health Center partner with us to offer CEUs, so huge thank you to them as well. And just this morning, literally just this morning, I received our proclamation from the governor's office proclaiming April 23rd as Adverse Childhood Experiences Awareness Day in Illinois. So grateful to the support from the governor's office and all the champions and supporters and people who really want to ensure that children grow up in safe, stable, nurturing environments. And celebrating that and honoring that is just our little piece of how we do that. So very excited. I did not have this slide in until about 9:12 today. So that came through in the nick of time to share with you all. So, and I love seeing your reactions. So yay for the hearts and all the fun emojis. Again, I'm not going to read these bios. I could probably talk all day about our panelists and the amazing work they do. I will let them introduce themselves. But this is their bios. If you want more information, you guys will get this slide. I just, it's always awkward sometimes to read through the words of the bio. So I am going to stop sharing my screen now and turn it over to our very first panelist, Dr. Bart Klika from Prevent Child Abuse America.
Well, thank you very much for the introduction, and thank you all for being here today. I want to make sure that my screen is popping up. If I could get a thumbs up just to make sure that everything looks good. All right, thank you. So I am Bart Klika. I serve as the Chief Research Officer at the National Office of Prevent Child Abuse America. We've been around for over 5 decades, making sure that no child experiences abuse or neglect. Our mission is around primary prevention. And in the past couple of years, we've put together what we call the Blueprint for Family Wellbeing, which is really our theory of change for how it is that collectively all of us can work towards this North Star of ensuring that all children and families are living a purposeful and happy life with hope for the future. Now, before I jump in, I'm going to kind of do some context setting about ACEs, talk some about promising strategies for the prevention of child abuse and neglect. And I've got a lot of slides. Want to let you know that my slides are going to be available, so you don't need to feverishly take notes on some of the things that I'm sharing. Very quickly, at Prevent Child Abuse America, we do our work largely through 2 big networks. The first is our chapter network, of which Prevent Child Abuse Illinois is part of. And then our Healthy Families America evidence-based home visiting program, where we have nearly 550 sites across the country working directly with kids and families in communities. So it's probably no surprise to anybody on this call when we use the term adverse childhood experiences. I don't often refer to it as the adverse childhood experiences study. I more refer to it as a framework. And it's more of a framework for understanding how things early in life can have an effect on us throughout the life course. The original ACEs study looked at these 10 things that could happen in somebody's life, but we know from other studies that have been done over the years that these are not the only 10 things that can happen in people's lives that have an effect over time. There's plenty of research to show that when these things occur early in life, there's many what we call downstream consequences. And so that can be things like mental health challenges, maternal health problems. It can be health risk behaviors, drinking, drugs, things like that. but also life opportunities. And so, how somebody is doing later on in life, related to work, high school graduation, those types of things. But perhaps one of the most compelling things that people talk about with the ACEs study is how adverse childhood experiences have been linked to some of the leading causes of death in the United States. Now, we've tried to quantify, and by we, I mean the larger field, about what's the toll economically that things like child abuse and neglect take. And so, researchers from the Centers for Disease Control and Prevention back in 2018 estimated that every child who experiences abuse and neglect incurs costs of nearly $830,000 in treating the consequences of abuse and neglect over their lifetime. So these are not annual costs, but they are lifetime costs. And those are things like child welfare costs, juvenile justice, special education, those types of costs. Now, we've done some work at Prevent Child Abuse America to actually update this estimate, not changing how it was calculated, but just putting it into adjusting for inflation. And what we see is that it bumps up to about just over $1 million per child victim when you adjust for inflation. So what does that mean here in Illinois? What that means is if we just look at those cases of abuse and neglect that occurred in the year 2023, that group of kids over their lifetime is going to incur costs of nearly $36 billion in treating the consequences. And so we know that there is a huge economic toll that is taken with child abuse, neglect, and other ACEs. Our president and CEO, Dr. Melissa Merrick, before coming to Prevent Child Abuse America, led the Adverse Childhood Experiences portfolio at the Centers for Disease Control and Prevention. And one of the last things that she did before she left was answered this critical question. If we were to prevent adverse childhood experiences, how much of those negative downstream consequences could we prevent? And what they found was that if we were to prevent ACEs, we could prevent upwards of 44% of cases of depression, nearly 33% of cases of smoking, 24% of heavy drinking episodes. These are the types of data that we use to make the case for the prevention of child abuse, neglect, and adverse childhood experiences more broadly. Now, like I said, at Prevent Child Abuse America, we've developed our framework or our theory for how it is that we think collectively as a field we can move forward towards the prevention of child abuse and neglect. But I've said it before and I will say it again. There is no one single strategy, there's no one single policy, there's no one single model, nor is there one single organization that is going to be successful in preventing child abuse and neglect on its own. Child abuse and neglect prevention, we know, occurs in partnership, and it occurs when we create what we term an ecosystem of support for kids and families. That includes policies and programs that support financial stability and economic mobility for families. It is policies and programs that support health and well-being. That can be healthcare, mental health treatment, substance abuse treatment, but also the types of programs that support kids and families like home visiting services and family resource centers. And finally, we know that many families succeed in the communities where they are living because of the robust support networks, informal support networks that support so many families. So if there's a message that I want to highlight today is there's no one single strategy or policy or organization or approach that is going to prevent child abuse and neglect on its own. We really need this full ecosystem of policies to support kids and families. I, for the remainder of today, am going to really drill down, though, into one particular section, and that's that financial stability and mobility section, looking at policy as a strategy for the prevention of child abuse and neglect. So let's quickly look at what some of the science says about policies and reductions in child abuse and neglect. There's research to show that for every $1,000 increase that a state spends for those individuals living in poverty within their state, so you have a $1,000 increase in spending, you see reductions in child abuse reports, substantiations, foster care entries, as well as child deaths. So that's spending on programs that support those living in poverty. Also, there's research to suggest that SNAP is associated with reduced reports of child abuse, substantiations, foster care entries, but also intimate partner violence. The interesting thing with SNAP and some of the other programs, though, too, what we see is when the administrative burdens or those things that make it difficult for a family to receive or to keep the benefit, when those burdens are high, we see these programs as less effective. There's research to show that Medicaid expansion has been associated with reduced child neglect. That means that states who have expanded Medicaid compared to those who have not see reduced rates of child neglect. There's been a lot done on the issue of the Earned Income Tax Credit, or EITC. Early work in this area showed that the refundable version of the Earned Income Tax Credit was associated with reductions in statewide hospital admissions for abusive head trauma. Subsequently, researchers have found that as earned income tax generosity increases in a state, we see reduced child abuse and neglect. And timing of the earned income tax credit and child tax credit is also important. Some researchers did some work looking at how quickly do we see this benefit of reductions? And what they found is that within a week of receiving these benefits, we see reductions in child abuse and neglect, and those reductions last for nearly 3 to 4 weeks following the distribution of payments. Some of my own research has looked at the effects of child care subsidies on child abuse and neglect. And really what we find is that more expansive child care subsidy policies, meaning the more families that qualify for a child care subsidy policy, is associated with reduced child abuse and neglect. However, like we talked about with SNAP, when administrative burdens are high, when we make it difficult for a family to either get or to keep a child care subsidy by putting in things like income cliffs or short redetermination periods, we're making families reapply very frequently. When those things are in place, we actually see reduced benefit of these child care subsidy policies on child abuse and neglect. And then finally, another area that I've done some work in is the area of paid family leave. And in general, what has been found is that one of the first studies to look at this was in the state of California, which implemented a state paid family leave program in 2004. And they found that compared to states that didn't have a program, they saw reduced rates of hospital admissions for abusive head trauma following the implementation of paid family leave. And more recently, we've been able to demonstrate that for those states who have implemented a state paid family leave policy, they have lower rates of infant maltreatment compared to those states that don't have a state option. More recently, we've seen some research, some of it coming out of RX Kids over in Michigan, looking at the effects of unconditional cash transfers, giving families money. And that what we're seeing is that giving families a modest amount of money is actually showing to be associated with reductions in child abuse and neglect. Here in Illinois, researchers from the University of Illinois and Brightpoint are doing a really fascinating study evaluating some unconditional cash transfer work. So we're excited to see some of the results coming out on that in the next couple of years. Now, largely to this point, I've been talking about reductions in child abuse and neglect, but really I've been talking about reductions in physical abuse and neglect. and haven't talked that much about the reductions in child sexual abuse, another adverse childhood experience. And what we see is that when the studies that have looked at economic and concrete supports and reductions in child sexual abuse largely have found that those policies don't necessarily reduce child sexual abuse. Now, the caveat to that is some housing policies have been linked to reduce child sexual abuse, but in general, concrete and economic support policies are not necessarily associated with reduced child sexual abuse. So, what does that mean? That means that we need different strategies than just concrete and economic support policies for the reduction of child sexual abuse. Now, in closing, for those of you who are interested in this topic of preventing child sexual abuse and what youth serving organizations can do, the CDC in 2007 authored a report on preventing child sexual abuse in youth serving organizations. In the past few years, there was an update to that report. We've recently, and when I say we, Prevent Child Abuse America, have released that report. We've been asked to be the official dissemination partner for that report. And so you have a QR code here on the screen to link both directly to the report, but also to our upcoming webinar on May the 7th at 1 p.m. Central Time, where myself and the authors of the report are going to be talking about how it is that we can create environments where kids can be kids and they can go to youth serving organizations and really get the full benefit from these programs. In closing, if we want to prevent something like adverse childhood experiences or child abuse and neglect, we've really got to get to many of the root causes. And a lot of what I talked about today was that root cause of economic stability and economic mobility opportunities for families. And so ensuring that families have what they need when they need it in the communities where they live before they find themselves in crisis. Here is my contact information. Again, like I said, I'm going to make my slides available. I look forward to hearing from the other presenters and to joining you for the Q&A. Thank you.
Thank you so much, Dr. Klika. I've always learned something. I've heard you present several times. So thank you so much for sharing your time. To keep us moving, I'm just going to send it right over to Dr. Saxon from the Department of Children and Family Services.
Thank you so much. Let me get my slides up. I really appreciate Dr. Klika's presentation, and it really aligns with what you all will see here. So as we talk about well-being and well-becoming, that is part of one of the things that we discovered as we have continued our research at Illinois Department of Children and Family Services about well-being and well-becoming. My name is Dr. Verletta Saxon. I'm the Deputy of Research and Child Wellbeing at DCFS. What that means is I'm over several programs that, for us, many of these programs, or almost all of these programs, build what Dr. Klika called an ecosystem. And so for us, in my department, we are over programs like intensive placement stabilization, stabilizing youth once they come into care, to ensure that they have that stable home environment. We have a program called Crisis Cares Community, which ensures that children who go into the local hospital emergency department, if they are not hospitalized for a psychiatric issue, that someone is there to assist them in getting the support and the medication that they need once they leave the hospital. We have high fidelity wraparound, early childhood court team, which is a team that really focuses on child development under the age of 3. So in that first 1,000 days of life, that is when children that's when all of their brain development is happening. And so we want to bridge that gap between what is happening with that child in their developmental stages, what is happening at court, what is happening in their case management, and ensuring that they have more opportunities for time spent with the parent so that that child develops well. We have all of the family first evidence-based interventions like TFCBT and MST. We also have motivational interviewing. We do healing centered engagement. We have our Erickson program that focuses on home visiting and early intervention navigation. It is really difficult for families to navigate the child welfare system and another system. So we want to make sure that children under the age of 5 who need those services can get into those services. So we have a team of people who help to open the door and get those youth across the street to home visiting and early intervention. So they provide a lot of navigation for that population. We also have a coaching program. That coaching program is just starting. So our coaches will be with all supervisors, whether they're with DCFS or a CWCA agency or our private agencies. That supervisor will be with that coach will be with every supervisor for the tenure of their career as a supervisor. And that is to provide that supervisor with the kind of support that it takes to critically think about cases and the families who are coming in and how we want to approach those families, how we want to approach those assessments, and how we want to provide that support. And then over leadership training. So all of those things, even though sometimes they seem very disparate, is really to build this foundation of what it means to have well-being and what we call well-becoming. It sets the foundation for that, not because they're programs, but because of what they actually provide. So when we think about families in child welfare, we think about, when you see a bridge, it's typically like, can the families, we're getting families to the other side of the bridge. But families are traveling across that bridge and they don't arrive empty, right? They're bringing their experiences, their stresses, their strengths, their histories. And the journey is already in motion when we actually meet those families at our door. So our role is not to start their journey, it is to transform the experience of their journey while they're on the bridge. For us, the bridge is when we think about bridges, we focus on where they're taking us. We really think about what they must carry every day in and out under the constant pressure. So in child welfare, we really see our staff as the bridge. So they carry the weight and that cumulative weight of family trauma, system demands, and urgent decision making. The system really depends on that bridge to hold. So staff really carry that heavy load, but only when they are intentionally reinforced and maintained do we find success for families and for our staff. So as we think about, families going over this bridge, some of those families are in smaller cars, right? They have some manageable stressors. Some are in these big SUV trucks. They're heavier, they're burdened, they're more complex needs. Some are overloaded, right? Their trauma is spilling out. It is uncontained experiences, and some are moving at 90 miles an hour, right? They're in survival mode. Everything is urgent. Everything is based on instability. So each vehicle is telling us a story about what that family is carrying. When they come into our door, similar to the ACEs, like they're receiving these assessments that tell us where the families are coming from. So before they even enter the bridge, they have their past traumas, their current stressors, system involvement, strengths and resiliency, their identity, culture, and their values. And not everything is visible to us, not even at that front door. Some experiences are really falling out. Some of them are uncontained, some of them are hidden, and they're all overwhelming. And too often as a system, the system itself feels fragmented, transactional, overwhelming, it's fast-paced and very reactive for our families. So if we're not able to really to sustain and hold the families, like because we're the foundation of that bridge, they keep moving at that 90 miles per hour. They keep getting faster and faster. And not paying attention to what is actually coming apart or falling apart for them, right? It's not always seen. So what we do in our office is that we really build this bridge of well-being. Um, we've done 2 studies so far. That first study really was our university partners and DCFS staff and individuals with lived experience coming together to define what well-being really is. And we came up with a definition that is similar to what you see on the screen. And then we did the same study again. So our second study really focused in on our second study really focused on only individuals with lived experience defining for us what well-being is to them and what well-being really means. And this is the definition that they helped us to create. That well-being is an individual's current state of health, happiness, prosperity, and stability, shaped by their experiences, opportunities, adversities, and values. It encompasses 6 domains. But as we think about this, historically, the definition of well-being has only been to the extent that well-being is about happiness. What the individuals with lived experience told us is that it's not just about happiness. You have to include the adversities that they face also, because those are the things that also help them to understand their well-being. And it doesn't, just because you experience something that is adverse doesn't mean that your well-being is bottomed out in any way. And so we included that in our definition of well-being. Um, and it helped to really extend us. And that's what I love about hearing from people with lived experience, right? We do a lot of research that is really human-centered design. We want to hear from the people who are most impacted by our systems. We want to hear what they have to say. And then we want to not just think about what they have to say, we also want to do something with it. And we want to have it change the system and change how we see the work so that we can then begin to do work differently. The second different definition that they helped us to really see and understand was not just well-being, but the idea of well-becoming, right? So all of us have well-being. All of us, no matter where we are, no matter where we sit, we're all striving to feel whole and to feel regulated, right? And to feel like you matter and that somebody matters to you. And so as we think about well-being, we know that all of our well-being changes, it adjusts, it becomes something different. If you injured your leg today, like if you broke your leg, tomorrow your well-being would be different. If someone that you cared about passed away today, tomorrow your well-being would be very different. So well-being is one thing. Well-becoming is referring to the growth that it takes and the effort that it takes to adapt and to improve your well-being over time, right? That at some point your well-being will not be what it is right now, and it will grow or it will adjust. And maybe something happened and it wasn't the best thing or the thing that you wanted, but your well-becoming changes and adjusts over time. And then how do we account for that growth? That's where we think about well-becoming. It is about growth, identity, purpose. It's about future orientation. And without that foundation, the bridge itself that we talked about, it cannot hold. So as we continue on thinking about well-being, there are 6 different domains for well-being that these individuals with lived experience helped us to really define. What I loved about Dr. Klika's presentation is that when we first started talking about well-being, economic stability or economic security was not a part of what we thought about in well-being. But this group of people were like, oh, you got to put that in there. You absolutely have to have it in there. There were 2 places that we added to well-being. So some of these things you would typically see, even if they're not in the same category. So physical health and mental health is something that you would typically see. Education and cognitive health is something you would typically see. But economic security is something that you would not see. Economic security for these individuals is, one, do you have what you need? Do you have what you need financially in order to survive, right? And we say financially, but all of it isn't financial. If you need diapers, you don't necessarily need the money, but can you go someplace and get diapers, right? Sometimes those things are actually they're available to you, but you don't have to actually spend any money on those things. And can you survive after a financial crisis? Those are things that this group of people told us you absolutely have to have in there. The second thing they told us that they really wanted, and I want to be really clear about this, is connection. So when we typically think about connection as a system, we think about connecting the people to a service. We think about connecting people to another person that cares about them. But when the individuals with lived experience, particularly our youth, said, "Hey, when we say connection, what we mean is as a large body, as my case worker, as my caregiver, when you communicate with me, can you communicate with me like you see me and you hear me?" Which is very different than what, as a system, we typically want to do. We want to get them connected with someone else. This puts the responsibility onto the system to actually see and hear the people for whom we are communicating with and we are talking to. The other thing that they shared with us is that they really don't like to be called resilient. They said, for them, resiliency is different than maybe for some other people, right? Resiliency for them was they felt like people said it to them so that the person who was speaking could feel better, not the person who was listening. And so as we continued this conversation with them, they said, like, for us, when you call me resilient, it's like the man who's pushing the boulder up the hill, right? I'm trying to push this boulder up the hill, and but the boulder is not one that I chose to take on. Like, this is a life circumstance that wasn't my choice. I don't like it, but it's still my responsibility. So am I doing something to maybe get myself stronger mentally? Maybe, but it was still not my responsibility. And so they felt like they did not want individuals to say that to them. For them, they also equated it to, you may have heard more and more Black women saying, like, don't call me a strong Black woman, right? Because that gives more responsibility to me than I have asked for, that I am looking for, and I don't want that additional responsibility. And so these are the six domains. We also have safe and secure environments, which would have been another, it's separated out from some of these other ones because they separated it, but it would have been included before in some of the other domains. When we think about what reinforces that bridge, right? That is the six domains, right? The physical and mental health we see as our strengths. That's another piece of what we are coming across, is that even though systems ask about strengths, oftentimes they don't know what to do with them. So the question becomes, not just that you asked me about my strength, but then what did you do about that? And that's what I love about healing centered engagement, is that you figure out what you actually can do with people when they start talking about their strengths. And so I'm really excited to hear Dr. Smith talk more about healing centered engagement. Safe and secure environments, that's where we find that durability at. And then education and cognitive health, we find a lot of flexibility. And then connection is longevity, and then economic security is our direction and where we're going and how do we get there. So overall, we're really trying to move from this idea of things being exclusive to that trauma-informed lens. We know we still need it. We still want it. We want to ask questions about trauma, right? Because that's a part of our system. Is what we do in order to understand families better. But we also want to start thinking about moving from trauma informed all the way to where families are thriving, right? And that shift requires ongoing support for well-being and for well-becoming. So as we begin to think about layering on this healing, we're acknowledging experiences without defining people by them. restoring that connection to self, to others, to community, and then creating space for regulation and reflection. So healing stabilizes those who are driving those vehicles so that they do not have to move so fast. And then even if the roadway gets complicated and it's, stretched out, we try to make sure that we are staying with them when the road gets complicated. And most of all, we want to make sure that things are designed and not hoped for. So when we think about well-being and well-becoming as the foundation, um, that healing is intentional. Like we're thinking about that. We're thinking about the end before we think about the beginning, and families don't just cross that bridge. They experience their lives very differently. Okay, Kristen.
Thank you so much, Dr. Saxon. I just wanted to share, I've seen some like just affirming statements coming in the chat and the Q&A. People really love the term well-becoming. And I think in your, conversations about like people don't want to be like told they're resilient. Somebody put in the chat, they have the same idea of those who are survivors. They are labeled as a hero and they never really wanted to be one. And that the resonating that resilient implies that they had a choice. And saying like things like your trauma made you stronger. It does not. It makes you just traumatized. So I think your message is definitely resonating with our attendees here today. So thank you guys for sharing those thoughts. Somebody did have a question about your 6 domains. They only saw 5, so
Yeah. So I think I misspoke because we had 6 before and then we reduced it
okay.
to 5. So there are only 5. We did have 6 the first time that we did it, but we also they were reduced. The second thing I will say is we are continuing this study outside of DCFS, so we're partnering with DJJ, IDPH, DHS to continue the study. If there are more state agencies out there that would like to continue this study with us, we are definitely open to that. We want to hear from you about how we might partner together in order to continue this study.
Wonderful. Thank you so much, Dr. Saxon. I think that's everything so far. So I am going to let Dr. Smith introduce herself and I will share her slides for her. So Dr. Smith, just take it away.
All right. Well, hello, everyone. Good morning. I am so happy to be here with you today. I am Dr. Mashana Smith. I'm a clinical community psychologist with the Childhood Resilience Center, also known as CCR, at Lurie Children's Hospital of Chicago. Our center has been around a little over 20 years now, and for the past 20 years, we've been dedicated to finding solutions for children's mental health. Most of our work has been in partnership with schools and community organizations, 2 systems that families rely very heavily on to support with mental health. So currently at the center, I lead the Resilient Supportive Schools Illinois initiative, which I'm going to talk about today. It's a partnership between ISB, where we help schools to build their capacity to support students' resilience through social and emotional learning, mental health intervention, trauma responsive and healing centered practices, as well as culturally responsive and equitable policies and practices. But before I stepped into this role, I had some of the same roles as some of you. I was a practitioner in schools. I made lots of home visits as a part of my role as an early intervention provider. I supported students and families in early childhood, specifically Head Start, and serviced young people in our residential group homes across the state. So I know the work that you do. I know that it matters, and I appreciate you taking the time to be here with us today. Just to share a little more about our team and our center, here we are. We are a multidisciplinary team comprised of clinical psychologists, licensed clinical social workers, but also researchers. And we are part of the Department of Psychiatry. And while we're a part of it, we know that not all families are able to easily access our hospital. Hence, our center is really public facing and a public health arm of the hospital. And collectively, our goal is to increase access to both mental health services, high quality mental health services in the community, as well as to offer and build up prevention programming in the community for children and families across Illinois, and we actually do some work nationally as well. But our goal is to ensure that every child in every community is safe, is supported, and I'm going to use that word that Dr. Saxon just said folks don't like, but resilient, and I'll talk more about that and define it, and thriving. And we do this through an upstream approach. And so I want to walk you through today the upstream approach that we use to do our work. Unlike traditional psychologists who may work with individual children, we utilize an upstream approach to provide systems, particularly early childhood systems, K through 12 educational system, our out of school time systems, to provide these systems with the tools that they need to address children's mental health problems. And in order to employ this upstream approach, we have to ask ourselves a few questions. First, we must ask, who are the right people to bring together? We know that we cannot do this work alone to the point that it's been made by my colleagues. We can't do this work alone. So identifying who are the other partners, which other systems have a vested interest in the same problem of really improving children's mental health and well-being. Next, we know that we must consider how we want to change the system. When possible, it's ideal to begin with how others have changed similar systems, looking at the research, looking at what is evidence-based, but then also knowing that we need to step outside the realm of evidence-based successes and interventions, if you will, and really think innovatively about what's possible and consider innovative strategies. And then we must identify those points of leverage that exist within systems already. And last but not least, measure impact. How well are we doing? How will we know when we're succeeding? So I want to talk a little bit about all of this. I want to start by just acknowledging where we are at this moment in time as it relates to children's mental health that many families are struggling with and dealing with. Some of you may know that about a year and a half into the pandemic, the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, the National Children's Health Hospital Association, all came together and jointly declared that we were in a national emergency in child and adolescent mental health. And we are very much so still in a state of emergency. So that is, I just want to kind of state or set the frame for where we are, what context we're operating in right now. But I also want to bring it closer to home and focus on Illinois. Here in Illinois, believe it or not, up to 15% of children between the ages of birth and 5 are already experiencing mental health struggles. And nearly half of our high schoolers are reporting feelings of sadness and hopelessness, feeling that way every day for up to 2 weeks, which really kind of marks clinical depression. And though we have fairly high prevalences in our state, we do have reason to be proud. In our state, and this map depicts this, in our state, our data is actually looking pretty good. We have found that I've been following this data since 2020, and we have improved over time from being 27th in the country to being second in 2024. And you can see in the table we had a slight decline, but we are currently ranked number 8 in the country in terms of states who are providing mental health treatment and supports to their youth in need. And so you could just see from the table that we have consistently improved, with the exception of that decline recently, but we've been consistently improving in terms of a state who wants to make sure that we are meeting the mental health needs of our young people. And for those of you who are like me, you just want to understand how these rankings came to be. And so they take into consideration both the prevalence of mental health problems among our youth and the treatment rates among youth. And I think we have reason to celebrate. We're seeing a lot of return on investments in the policies that we've been putting forth to improve youth mental health. This includes the Children's Behavioral Health Transformation Act that was passed, our Children's Adversity Index. We had the Healing Centered Illinois Task Force, our Social and Emotional Learning Hubs, and then also an intervention I'm going to talk more about, Resilient Supportive Schools Initiative, that we have been doing for the past 5 years here in the state. I do also want to mention a recent policy development, and that is universal mental health screening. I'm sure many of you know that this public act was passed this past July. And just for level setting, universal mental health screening is a process whereby entire populations or subpopulations are screened for mental health difficulties, and those scoring above a predetermined cutoff score that is defined. In our cases, we're going to be looking at 3rd through 12th graders in the state. Universal mental health screening is arguably the best way to leverage this peak window that we know we have for intervention when young people are experiencing mental health problems. About 50% of mental health problems have their onset by the age of 14. And we have a peak window and opportunity where we can intervene to really decrease the severity of those mental health problems. Universal mental health screening has been used in other states, albeit it has not been adopted as legislation and mandated the way it will be in Illinois beginning as school year 27-28. But it is arguably the best way for early identification, prevention, and early intervention. So some exciting policy that we're doing here in the state of Illinois. Why are we doing this? For a number of reasons. We know that one, public school attendance is a legal requirement. So from an equity standpoint, it's an opportunity to reach all students, all youth who are attending school. It really, like I said, increases the chance for prevention and early identification. We also know that schools have a long history of screening. They are known for lots of screening, whether it's vision screening, hearing screening, screening for academic difficulties. And so schools have a long history of all of these screenings. And then the third reason that I'll point out, interestingly, some research has even found, and this is some international research in Australia, that universal mental health screening in schools doesn't always result in a formal referral and treatment to a provider, but just getting awareness and feedback to parents and to students can actually positively impact students' mental health. So just some really solid reasons and solid research to support universal mental health screening policy. Interestingly, the research tells us that families rely pretty heavily on educational settings for mental health services for their children, particularly adolescents. Youth are almost as likely to receive mental health services in an educational setting as they are in a specialty mental health clinic, if you will. In 2019, there was a study that found that 15% of adolescents between the ages of 12 and 17 reported receiving mental health services at their school. And this is compared to 17% of those adolescents reporting that they received it in a specialty clinic. I think this is something that a lot of people don't realize or recognize, that in many ways, the school system has become a de facto kind of place of service for the receipt of mental health services, since we really want to have some wraparound services and wraparound supports to support our schools, our educators, our school-based mental health clinicians in supporting young people. Now, we'll say whether these services are provided in schools or clinics, the reality is that we will not be able to mental health our way out of this need that exists among our youth. Our current workforce shortage simply won't allow us to. Quickly, you can see in these pie graphs here that only about 50% of our school psychologists and school counselor positions are currently filled. And then you can see about 2/3 of our school social work positions are filled. But the reality, is one, we have a workforce shortage, but also I'll add that another reality is that not all children who have mental health concerns require mental health treatment. And there is research to support that it would behoove us to focus on resilience, which I'm going to talk about. So you may have seen resilience defined as a child's ability to bounce back from challenges or stressful situations, to be able to manage their emotions, adapt to change, and keep moving forward. And I really appreciate the point made by Dr. Saxon and her research in the community and the negative perception of that term among certain groups for, legit reasons, right? And I do want to say that resilience isn't just about surviving hard times. It really is the way we're looking at it, it's about thriving. Those same traits that allow for one to bounce back and rebound also really lay the foundation for healthy connections that Dr. Saxon mentioned, for being able to have a community impact and lasting mental wellness. And so we want to build resilience, though, through developing healing-centered environments. And I want to talk more about that. What I thought I would do now is share a case example, the way in which we've done this with the Resilient Supportive Schools Illinois, and just walk through this upstream approach that we're using across the state of Illinois to support our schools. So knowing that an upstream approach requires us to unite the right people if we want to develop a upstream approach, but developing real resilience and healing-centered environments, we want to unite the right people. So in our case, once we were approached by ISB, we wanted to unite one, funding is always needed. And so we were able to leverage federal dollars that were able to support this work. So that's probably first and foremost. I know we all need funding, but also we wanted to partner with a number of implementation partners who were around the state and who had expertise in different areas to really build out a program that could support the resilience of not only students but educators, and really build resilient schools and systems is our goal. And so you can see we partnered with a number of organizations. Some may be familiar to you. The Partnership for Resilience, Stress and Trauma Treatment Center, ISB, of course, was our state agency partner, and partnered heavily with the Illinois SEL Hubs. I'll talk a little bit more about that later, but then had some other partners who were really instrumental in building out the resources and tools that we wanted to be able to provide systems. So the first step in just building that approach was us thinking and being very strategic in the identification of partners who too had a vested interest in improving the mental health and well-being. This was particularly time when this effort was launched, which was back in 2021 when we were at the height of the pandemic and we were seeing all of the negative impacts on well-being and mental health among not just the students and the families, but also among educators themselves who were trying to support students. So next, we know that an upstream approach requires us to move beyond changing individuals to changing the systems. And RSSI, the Resilient Supportive Schools Illinois, is an initiative that does just that. So RSSI is free, completely free to educators, but it is an assessment to action, an evidence-informed initiative for K through 12 schools that uses school-specific data to help schools understand what are their strengths, what are their weaknesses, and for particular areas. How are they doing as it relates to promoting social and emotional learning and teaching social and emotional learning skills that are beneficial and actually do also impact academic well-being and functioning within schools? One pillar. Two, able to assess how are they doing with regard to mental health promotion and prevention and intervention within schools. So what supports are available to support students, and really assessing what do they have available at those different tiers. Tier 1, that's for everyone, or Tier 2 and Tier 3. The third pillar is related to trauma responsiveness and healing centeredness. So assessing what are those trauma-informed policies or procedures that they have in place, if any, right? And getting a gauge on where their strengths are and where their weaknesses are in that area, where there's room for growth. And then last but not least, helping them to assess where they are in terms of culturally responsive practices, intending to meeting the needs of diverse groups within their school environments, and assessing and reflecting on their policies and practices in that space. So RSSI focus on those 4 pillars, and then schools are able to utilize their data after they've done the assessment to really make a decision on which area is of greatest need, one, and can impact the most students by creating a safe and healthy, resilient learning environment for students. RSSI also provides educators with access to a wealth of on-demand courses and resources to prepare them to be able to support student mental health and resilience. While also we know that educators need to foster their own strengths and resilience and self-care skills. So again, this is all about changing the system, which is critical. On this next slide, you can just see some of the offerings that are offered. Right now, we do have about 24,000 users on the platform, and these are courses that I will also provide a QR code that any of you can feel free to access that can support you in your work with young people. The next question, in terms of building that upstream approach, we know that it requires us to identify points of leverage. And what we did is we leveraged the newly established, fairly newly established, it was new at the time, newly established infrastructure that includes SEL hubs in each of the areas across the state. So hubs had relationships with school districts and schools. They had expertise in social and emotional learning to support as regional coaches to help schools navigate through RSSI and identify the resources that are most essential to them in their respective areas. So what I just encourage you to do is you listen to this, is think about what are those systems or structures that can be leveraged in your world or your ecosystem in order to help you really think upstream about, interventions and programming that will benefit all youth. And last but not least, an upstream approach requires us to measure success. And so we wanted to do that, and we measured teacher retention, we measured student discipline practices, as well as student attendance. This slide may be a little difficult to read, but what we were able to find through providing and implementing this upstream approach in our schools is that teachers reported higher levels, or schools reported, we were able to measure higher levels of teacher retention in schools that were really putting forth an effort to promoting resilience, addressing these four pillars within their school, is that teachers are more satisfied in their positions and more likely to stay, which is critical when we talk about one thing that builds resilience is that sense of connection, being connected to another adult, being connection to someone who cares for you. And students were able to benefit from this in schools that had RSSI because those teachers were staying longer. They were building and fostering those healthy relationships and a sense of connection with students. The other thing that we found is we looked at discipline data and records, and what we found is that in schools who were beginning to adopt these practices and really paying attention to trauma responsive practices, in particular healing-centered practices, is that they also saw a decline in the use of exclusionary discipline. So rather than excluding students, using out-of-school suspensions, for example, they were turning towards using a more trauma-informed, healing-centered lens and being able to view the behavior within that context and develop other interventions, if you will, and not use out-of-school suspension. So another positive. Last but not least, what we found when we looked at student attendance is that schools who were beginning to use this more upstream approach, focusing on prevention and strengthening culture and climate and resilience within the school environment, is that those schools also saw a reduction in chronic absenteeism. So students were coming to school, which matters. And it wasn't like a huge reduction in number. It was about 3 days, but the literature tells us that that's statistically significant for increasing student high school graduation, high school completion, and reducing high school dropout on the flip side of that. So all just really positive findings. So I just wanted to share this as an example of an upstream approach that we're using that can be used. This is something that's being used in partnership with one of the state agencies, ISB, but just has potential to be used across other state agencies and with other, populations and groups. So that is it. I'm happy to be able to share RSSI with you. And thank you so much for your time and allowing me to share in this approach with you.
Thank you, Dr. Smith. I'm just going to run back through the chat a little bit just to make sure that there was nothing that came in while I was sharing. It looks like Allie shared some really great things. Of course, she's Always my go-to as well. She knows all the things. So thank you, Allie, for engaging in the chat while Dr. Smith was presenting. I am going to lastly play it's about 15 minutes for you to hear from some of our elected officials on what's happening in the General Assembly in Illinois, some of the legislation they're proud of that contributes to supporting children and families, and then some things coming up the pike. You will also hear, interestingly enough, but kind of not with this group, they're going to reference several of the different policies and acts that you've heard from our panelists today. So I'm going to share my screen and play that. And then we will have a little bit of time for questions and answers. So feel free to throw them in the Q&A while the video is playing if you have questions for our panelists.
Good afternoon, and thank you for joining us. And why don't you spend a little time talking about your role as a legislator, and let us know a little bit about your priorities in Child Abuse Prevention Month.
Hello, everyone. So I'm Michelle Messman. I am state representative of the 56th district. Very, very glad to be here for today. I have been a strong advocate in the child abuse awareness space for a number of years since I ever got involved, and certainly have been involved with a number of agencies and a number of pieces of legislation over the years, one of which obviously was the creation of the simulated training lab, which I was very happy to be involved in. Currently, I'm on the board of the Children's Advocacy Center of Illinois and working with them on some pieces of legislation this year that we're hoping will have a bit of an impact. But yep, glad to be here.
Thanks for having me. And I am the state rep covering much of the far northwest side of the city of Chicago and a little bit of the suburbs here in Chicagoland. I myself come to elected office from the world of social services, and I have a master's in social work, and I'm technically a licensed social worker, even though I'm obviously doing my work at the macro level. But knowing that April is a really important awareness month, and knowing all the work I do in human services, in behavioral health, there was no question that I need my voice uplifting everything that we need to do to reduce trauma amongst our families and our children, including our youngest children. So I'm super happy to be here.
Good morning. Thank you for having me. It's an honor to be part of this program. I'm State Representative Anna Moeller. I represent the 43rd District, which includes most of Elgin, Carpentersville, Hoffman Estates, and Streamwood. I've been a legislator since 2014, so about 12 years now. And I think it's incredibly important that we as a state do everything that we can to prevent child abuse and to support families in our communities.
It's a really fundamental question. And when I think about that, my mind immediately goes to everything that we can do to reduce the burdens of poverty overall that far too many of our families have to endure day in and day out. And there are some tried and true mechanisms that we can do, some of which we are doing in Illinois, but my constant refrain is we're not doing enough of these things at the scope and scale that matches the need. But a great example of a specific lever to reduce poverty is the Earned Income Child Tax Credit, a mechanism that when families file their taxes, families that have kids under 12, it immediately puts more money into their pocket. It reduces poverty immediately. So we are on a runway to increase that here in Illinois, which is a great thing.
I think there are a myriad of ways that we can do that at the state level. And I think that we do that, but certainly, we need to continue to bolster and increase investments in these areas. And I think of programs like the home visiting program for new parents, especially parents who may be single parents or younger parents who may not have the family support that they need when they bring home a newborn. We have programs throughout the state where nurses and trained caregivers will go out and help, with nursing, breastfeeding, to answer questions about newborn sleep and, taking care of a newborn, and just to be there as a support for new moms and new dads.
It's a little bit of everything, right? I mean, I think at the end of the day, you have to ask if a lot of people's basic needs are being met, right? When you have added strain, whether you're hungry, you're housing insecure, you're job insecure, you're health insecure, right? If you're not having access to even regular checkups, you have undiagnosed high blood pressure, undiagnosed mental health problem, you are trying to self-medicate maybe with different substances, all of those things sort of contribute to this pressure cooker that can make people act in a way that I think maybe they wouldn't ordinarily act. I think you lash out unpredictably. So what is the state doing to make sure that people have consistent access to food, consistent access to childcare that allows them to hold down a high-paying job or a job that meets their needs? What are we doing to make sure that we're raising up wages and making sure that families can keep as much of their money as possible? Like when you're looking at the childhood tax credit, right? Every little bit that a family can keep at home is going to help alleviate a little bit of those pressures. We're having big conversations around affordable housing right now. We know that many families are housing insecure, and if they have housing, they may be paying too much for that, and that's not leaving enough financial resource for other pressures in their life, or they're living doubled up with other families, with other relatives, and that too is contributing to a lot of tension and anxiety that I think just contributes. As the state hopefully has enough money, you create those grant programs that help any of those organizations maybe hire that other staff person that can full-time act as the intermediary. I think sometimes we have a lot of good intentions, but it's no one person's job to see it all the way through and connect all the dots. And I think a lot of things can kind of fall by the wayside. So when you have grants and things that can just give you a little breathing room to try something extra, that can make a really big difference.
And there are many ways we can get that. Some of it is better training for people that work in those spaces. Some of it is just better resources so we don't have holes in staffing and we have more stability in terms of retention of high quality staff. That's where I'm going to zero in, because one of my biggest priorities as an elected official is to make sure we're adequately supporting our frontline human service and behavioral health professionals with fair compensation and stable and quality work environments, so they will come to the field and stay in the field. And so much of that work is based on trusting relationships. And so the more we can support our frontline professionals, the better they can do to have strong relationships built on trust with our families, many of whom are extremely vulnerable.
One example that I can share is here in the U46 school district area, which is a big part of my district. We have an alliance of organizations that work together from newborn through high school. They work through the school district, and they bring together social service agencies and other stakeholders that have a role in supporting families and children. And they meet on a very regular basis to talk about what are the emerging needs in a community. What are they seeing in the schools, and what are they hearing from families? And they work to coordinate, those services, and to make sure that there aren't any gaps, and that families aren't falling through those gaps. in my role as the chair of the Human Services Appropriations Committee, we look at all of the state agencies that provide human and social service support in the state. And that's including the Department of Children and Family Services, the Department of Human Services, Healthcare and Family Services. Those are all very important agencies that make sure that families who need help get the help that they need, that children who need help get the help that they need, and making sure that they're adequately funded and that they're adequately staffed, and that they can do the job that they need to do, here in Illinois. There was a bill that passed 2 years ago, or last year actually, the KIND Act, which helps with kinship adoption and guardianship. And we're seeing, that's being used as a national model right now for children who need, whose parents aren't able to take care of them, keeping them within the family. Again, that's like a very personal, near and dear to my heart situation and issue. And it's leading to more children finding permanent homes. And so we need to make sure that we are implementing and strengthening the KIND Act so that children can stay within their families, even if their parents aren't able to take care of them.
Having different conversations, especially when you look at schools, around mandated reporting. Are schools able to better differentiate between neglect and just poverty, right? And offer more appropriate wraparound solutions for a family rather than necessarily the hotline call that can escalate. I mean, we know anytime an investigation is involved, it is traumatizing to the child and the family. And so we're causing harm when that may not be the tool that is needed, right? We know that the schools are trying to look at now, not just the academics for children, but that child as a whole, right? We know that if we're not addressing the ACEs that child is walking in the door with, we're not really going to be successful at providing a strong academic education. There's a lot more focus on social emotional well-being. Our schools are going to start doing mental health screenings, which will help identify maybe kids that have traumas that maybe their families are not recognizing or understanding. And then can we link kids and therefore families to more services in the community? Those are all really important. We're putting a lot more emphasis on teacher training, being able to recognize trauma, especially when you have behavioral outbursts that don't seem to come from a place you recognize. Especially one of the things that we're working on is better awareness around kids that are adopted, fostered, and immigrant families. They have a lot of attachment concerns and a lot of their emotional relationship to sort of that family. Those family differences or instability can really manifest, especially as they move into puberty and everything. And so you may have a child where everything was fine, suddenly start having an outburst and reacting very strongly. And again, it's kind of these developmental phases that they go through that a lot of people don't understand. And so when you're not kind of getting recognition for where that trauma might be coming from, and your response or your disciplinary tactic might actually just make the situation worse. And we know that there are tools and there are classroom management techniques that, that the teachers can use to be a little bit more sensitive to some of those family dynamic issues, and trying to get a lot more information out with the understanding that staff is already going through significant amounts of training, and they are very overwhelmed, and it's a lot. We rely heavily on our teaching staff to be all things to all kids when they were really originally trained to, teach, and now we're asking so much more of them.
A few years ago in Illinois, we passed a bill so public school students, K through 12, can take up to 5 mental health days off a year. And some students won't do that. But the idea behind this legislation is that it puts mental health on par with physical health care, but more importantly, it opens up conversations in families, between schools and families, saying this is an option for you. Your kids' mental health care is just as important as their physical health care. So if they are really, really struggling on any given day, it is very legitimate to call in and say, your kid needs a mental health day. And the other very direct thing we did related to schools recently is we passed a universal mental health screenings bill into law, meaning in Illinois, grades 3 through 12, starting in the fall of 2027, if we all stay on track, there will be universal mental health screenings, which is not an assessment. As the professionals know, a screening is much shorter. It is not in depth. A universal mental health screening in school. This was a controversial bill. There is an opt-out provision. School districts writ large cannot opt out because that would make it not universal, but families and students can opt out. And this is a way, the intent is to do a much better job identifying issues with just a screening on the front end so we can do a better job connecting youth and families to behavioral health resources. So it doesn't take 11 years for a child to be connected to evidence-based treatment.
What can average people do, right? And to a certain degree, it was a lot to think about, right? I mean, I think it takes a village. We all have to take care of each other. I know that there's a lot of stigma, I think, involved in that, and people do have differing views on how independent we should be versus how much we as a collective, care for our fellow man, right? But especially in situations like this, are you able to meet the moment with compassion, right? Can you take a breath and ask yourself, is what I'm seeing neglect or abuse, or is there more going on, right? And how can I help with that, right? Like, how can I offer an encouraging word? How can I babysit and give that family a little bit of relief, right? How can I be a good role model to that parent who's strained, or even to that child, right? We know what a significant impact one caring adult can have in the life of the child. And if that can disrupt some of these patterns of abuse, I think that's significant. And that's a thing that we can all do, is just be kind to the children that are around you in your life.
Yeah.
So it was really great to sit down with our elected officials and talk to them about the different policies at all the different levels, all the initiatives, all the programs. So I truly appreciate their time and their support along with our panelists. So we have a few minutes left. I am going to just start our panelists with a few questions. Don't see anything in the Q&A, which is fine because people submitted questions ahead of time, which was great with their registrations. This one I'm going to give all three panelists a chance to respond to. And we can just go in order of how you guys presented your slides today. But one of the questions was, we've heard the words trauma, hope, and well-being. How do these concepts fit together in a prevention-focused Illinois? So Dr. Klika, if you want to get us started.
Wow, great question. Trauma, hope, and well-being, I think within a prevention context, I mean, what we talk about Prevent Child Abuse America is coming from a public health approach, which is what we do collectively to ensure the conditions that all kids and families can experience health and well-being. I think hope is central to the work that we do. We do work to ensure that no kid ever experiences abuse and neglect by ensuring that kids and families have what they need, when they need it, in the communities where they live, delivered without stigma before they find themselves in crisis. And so when I think of the idea of hope, I think about all the people who are here. I think about all the great work like we heard about today going on. And it gives me personally hope for the prevention network across the state, but really across the country as well. And I think that there's things that Illinois is doing, which is really leading the way for the country. And so that's how I'd respond. I'll kick it to my colleagues.
So for me, as we think about those three terms, trauma, hope, and well-being, I would actually put them a little bit differently. I would put them trauma, well-being, and then hope. For us, We know that families and individuals experience trauma, that trauma impacts their well-being, right? So it may negatively impact their well-being. And on the other side of that is hope. So if there's a way for us to increase their well-being, if there's a way for us to focus on that well-being and to help them to get to the next place of well-being, which we talked about was well-becoming, we know with that comes hope. We know with that comes creativity. We know with that comes thriving. And so we feel like well-being is right in between trauma and hope.
Okay. And just to add to that, I think when we talk about trauma, in part, it can be a result of the different individual and family stressors that we've just heard the legislators mention and that we've mentioned. But clearly, trauma is also related to many social influencers, or what we used to call social determinants of health. So whether that's talking about economic instability, lack of access to high quality education and health, et cetera, I think all of these can lead to the experience of trauma. And once we begin to reduce some of these structural barriers that play a role in trauma exposure, I think that's when we can begin to offer hope to our children and families. And that hope, I think, can also play a role and lead to increased well-being and mental health in young people and their families. That's how I would see them all being related.
Thank you to all of you. I think those messages are extremely powerful and again, sure resonate with all of our attendees on today. I am going to get to a few of the questions just because we just have a little bit of time left that were submitted by people who registered for our webinar today. The first one is, and these are a little bit more specific. So whoever wants to chime in and answer, but I thought this was a really great one. How are DCFS caseworkers supported so they can support families' resilience when they have experienced trauma?
So for DCFS, the way that the caseworkers, right, are supported, what we're moving to is a new system where caseworkers are always supported through coaching. Historically, they have been supported by their supervisors and their leadership. So now we are really moving to a system where there will be coaches. Those coaches will be with that supervisor for the tenure of their career. And the hope is that we can help them to think more critically about cases and support the work as we continue to move forward.
Thank you, Dr. Saxon. Another one that was submitted at registration was how do we meet and help families that have children with complex medical needs and have faced medical trauma? And if some of these need a little more time for you guys to like resonate with and think, we can provide responses. I can just keep moving on if that.
I mean, I'm just speaking. I don't do that work in Lurie Children's, but certainly, I know our hospital has integrated care and consultation for all of the pediatric units. And so hospitals should be tending to wherever the recipient, the patient is receiving health care. Hospitals should have available kind of integrated psychological care that they're able to provide and address mental health concerns for those patients who do and are experiencing medical traumas. And so that would be my short answer to it. But making sure that you're connecting with pediatricians, and the research is showing that pediatricians are doing a lot more in the mental health space. So kind of advocating for parents and having parents advocate too for themselves to ensure that they're receiving support and that their child's medical related trauma is being addressed as well. That would be like the short answer.
Sorry, I just realized I was muted. Thank you, Dr. Smith. I'm going to leave it with one last question that all three of you can take a couple seconds to answer before we finish today. But I think it's really important. What role do partnerships across policy, community, and systems play in moving us towards that collective well-being?
I'm happy to jump in. I think I said it during my presentation, but this idea that prevention happens in partnership, that there's no one single organization, there's not a single program model, state that is going to be able to do prevention in isolation. Partnerships are key to this work. There are organizations that have expertise in particular areas. Not everybody can be experts in everything. And I think we have to realize, as organizations, as models, what are we strong at and where do we need partnership in building out our capacities, and how do we uplift other work that is being done as an organization, because this work requires all of us. And so prevention happens in partnership and only in partnership.
And I think for me, I echo the same thing that Dr. Klika said. For us, it is about partnership, but also about, how do we think about our current systems and, try to rethink the ways that we have practiced, coming with a different mindset. And that's one of the big things DCFS is now doing. It is also like that we only want to capture families that really absolutely need to be in the child welfare system. And we have admitted that we could have done better at ensuring that those families who could benefit from prevention and support services in the community are actually receiving them. And so that is really where we're going now, in the current work that we're doing is basically saying we want to provide the most support as early as possible. And we now have some of that funding that allows us to do that, from the federal government.
Yeah, so I too echo what's been said by Dr. Klika and Saxon. I think the only thing I'll add to it is partnerships are essential, and not just in terms of implementation. The partnership isn't only essential at the implementation level, but also at the funding level. So the more that we can engage in more public-private, I think partnerships, I think the better. And that's the only thing I did.
Well, thank you for those hopefully inspiring words to send us off today. Thank you to everybody who has interacted, put their questions and their thoughts in the chat. I put a link to request your CEUs and to complete a brief evaluation. Those links will also be included in the follow-up email. You will get a copy of slides and the recording as well, so you can reference back. But thank you all for being here. Huge thank you to our panelists, Dr. Klika, Dr. Saxon, Dr. Smith. A huge thank you to my colleague, Dr. Betsy Goulet, who helped with the recordings from our three Illinois representatives. And thank you all for attending. You will have my contact information, so if you're curious, you want more information, you can email me directly, or you can check out our website. We have a lot of great things as well. And that is all of our time to today. So thank you everyone for joining us, and enjoy the rest of your afternoon. Thanks, everyone.
Thank you.